Hello, my name is Patience Afulani. I'm an associate professor at the University of California, San Francisco. I'm pleased to share with you my leadership project titled Building Capacity of African Health Systems to Provide Person-Centered Care. At some point in our lives, most of us will encounter a healthcare provider for one thing or the other. When we do, we want to be treated in a way that is respectful and compassionate and is responsive to our needs, values, and preferences, regardless of who we are, who we know, or where we happen to go. This is my vision for person-centered care. And person-centered care is a crucial health indicator from both a human rights and quality of care perspective. My leadership project aims to develop a cohort of providers and leaders across different levels of the health system who are passionate about improving person-centered care and who will become its champions and advocates. My project takes advantage of my ongoing work on person-centered maternity care, which is basically person-centered care during childbirth, and is embedded within an ongoing study in Ghana and Kenya called the Caring for Providers to Improve Patient Experience trial, on which I serve as the principal investigator. This work was motivated by my prior research and that of others that highlighted poor communication and lack of autonomy, as well as neglectful, disrespectful, and abusive treatment of women during childbirth, with the most vulnerable groups having the worst experiences. My project thus seeks to improve person-centered maternity care through an equity lens by addressing two critical factors: provider burnout and bias, which are often overlooked in interventions to improve quality of care, but significantly contribute to poor and equitable care. Provider burnout leads to negative patient experiences, while provider bias, both implicit and explicit, contributes to inequities in care. The intervention employs 5 strategies: training, which involves sessions on person-centered care, stress management, dealing with difficult situations, and bias awareness and mitigation; peer support, which consists of monthly peer facilitator support groups to discuss problems, brainstorm solutions, and engage in stress management activities; mentorship involving one-on-one support provided by experienced providers to less experienced ones; embedded champions who are selected by their peers to lead intervention activities, including facilitating refreshers at their sites; and leadership engagement, which includes a community advisory board of leaders at different health system levels who provide input on intervention implementation and help to address sources of stress raised by providers. The intervention was previously piloted successfully in Kenya and were funded by the U.S. National Institute of Health for the current trial, which would involve 400 maternal health providers from 40 health facilities in Kenya and Ghana, randomized to 20 intervention and control sites. It is a 5-year project from July 2023 through June 2028. We started implementation in 2024, and so far have trained 200 healthcare providers, engaged 40 champions, and over 40 health system leaders, and will double these numbers by the end of the trial. We have also completed baseline data collection from 400 providers and 2,000 postpartum women. Data collection for the trial is still ongoing, but I am optimistic by the intervention's impact based on our pilot studies findings, which are published. The pilot study did show that the intervention improved both provider and patient experience. As one provider in the pilot said, "Sharing my stresses with my colleagues now made me enjoy coming to work, and my anger towards patients was also dealt with. Before, I could shout at the mothers without bothering that they are in pain, and that is why maybe they are not cooperating. But nowadays, it is not easy to find me shouting at them. I no longer insult the mothers." The intervention has been very well received, with calls for its expansion to all providers. My goal after the trial is to extend my leadership project by extending this work to all providers in the 2 countries, contingent on funding. I also look forward to partnering with implementers in other countries to expand the intervention beyond Kenya and Ghana. The leadership journey has been instrumental in my ability to lead this project in an authentic, inclusive, strategic, and impactful manner. Through this journey, I've also come to recognize how this work embodies my core values of compassion and contributes to my desire to decrease suffering and increase joy in the world. This has further increased my passion for this work, and I'm motivated to continue expanding it. Through the cohort of providers and leaders developed from this project and its expansion to other countries, we will build the capacity of African health systems to provide person-centered care. and make progress towards a world where everyone receives responsive, respectful, and compassionate care, regardless of who they are, who they know, and where they go. The leadership journey has also helped me see myself as a leader in this field, and I've learned strategies to increase my leadership visibility. It, however, takes a village to get this work done. And I would like to end by acknowledging my team at UCSF in Kenya and Ghana and all of my collaborators. Thank you.